other unilateral headaches with autonomic features. Cluster headaches are much less common than migraines and affect men 5 to 9 times more frequent than women. The pain most often in and around an eye may radiate to adjacent upper and lower face regions innervated by the ophthalmic and maxillary divisions, and less commonly the mandibular division of the trigeminal nerve. Typically, the pain is excruciating and a dull remnant often persists for between the attacks. Most patients' pain is in the same side each time. Commonly, cluster headaches interrupt sleep. In most cases, the headaches last 15 to 90 minutes. Unlike the migraines, seek to remain recumbent and immobile during the headaches. Many cluster headaches patients walk about and some apply pressure to the affected or the ipsilateral superficial temporal artery. Ipsilateral lacrimation, coryza, conjunctival injection, nausea, ptosis, and miosis, photophobia, facial flushing or pallor, temporal artery tenderness, and hyperalgesia of the face and scalp can precede or accompany the pain. Usually the headaches occur repeatedly 1 or 3 times per day over a period of 4 to 8 weeks, and then remit for months or years before another severe bout supervenes. Roughly the fifth of the patients have chronic cluster headaches that occur cluster headaches that recur frequently without any prolonged headache-free intervals over months and years. The same triptan medications that abort the migraines in a majority of patients are effective for some patients with cluster headaches. Alternatively, or in addition, inhalation of 100% oxygen for up to 20 minutes relieves up to 90% of the cluster headaches. Sublingual or inhaled ergotamine tartrate 1 mg initially with up to 2 repeated doses over 15 minutes can be effective alone or in combination with oxygen. In some cases, application of 4% lidocaine solution to the sphenopalatine fossa to anesthetize the sphenopalatine ganglion can promptly relieve the cluster headaches. The solution can be dripped along the lateral aspect of the nasal septum ipsilateral to the pain, or a cotton swab saturated in the solution can be inserted into the nostril and applies to the sphenopalatine fossa. During a cluster of attacks, prophylactic treatment to prevent the recurrent headaches usually is essential. Verapamil is the drug of choice. The dose is increased stepwise with the cautious monitoring for side effects, so as to as high as 480 mg per day. If ultimately required, side effects may include hypotension, intolerable constipation, or dependent edema. Alternatively, lithium, ergotamine, or methylsergide may provide prophylaxis. Prompt suppression of recurrent cluster headaches also may be achieved using prednisone, begun at a dose of 30 to 40 mg per day, and then tapered to over 2 to 3 weeks. Beta blockers and tricyclic drugs usually are not effective. Attacks of chronic paroxysmal hemicrania, often agonizing, resemble the cluster headaches and the associated autonomic symptoms and signs. However, they tend to last 10 to 20 minutes, recurring repeatedly 10 to 15 times during the day and night. Typically, they are chronic rather than clustered. Uniquely, indomethacin usually affords dramatic relief. Frequent 15 to 60 seconds duration unilateral headaches with cluster features that recur 5 to 30 times per hour have been termed short-lasting unilateral neuralgiform headaches attacks with conjunctival injection and TRE. These headaches are reported to be refractory to treatment with indomethacin or carbamazepine. So we come now to the end of this lecture session. I will come up with more information in my subsequent lecture sessions. Thank you.